All right, let's talk a little bit about hypoplastic left heart syndrome. And this basically represents the extreme end of left heart obstructive disease. And what it is it's essentially underdevelopment of the entire side of the left heart. So the mitral valve is small, the left ventricle is small, aortic valve is small, and the entire ascending and transverse aortic arch is small. And how these fetuses survive to be born term is that a patent ductus arteriosus allows blood to flow from the pulmonary artery across the PDA into the aorta to supply blood flow to the body. So this is ductal dependent critical heart disease. And the findings that you're going to see on echo are exactly what I described. So you will often see a small left atrium. You can see a hypoplastic or sometimes an atretic mitral valve. You will see a small left ventricle. It does not go all the way to the apex, and sometimes it can be actually hard to tell that there's two ventricles at all, because sometimes that left ventricle can be so tiny you literally can't see it. You will see a hypoplastic or an atretic aortic valve and a hypoplastic ascending aorta. So schematically looking at it, what happens in these babies after they're born, before any repair, is you have blue blood coming in through the superior and inferior vena cava. And that mixes with the pulmonary blood flow returning from the lungs into the left atrium. Now, because the mitral valve is stenotic or atretic, there's essentially no way for blood to get out of the left atrium, and so it has to cross across the patent foramen ovale into the right atrium. So at the right atrium is the point where you have mixing of the deoxygenated blue blood and the oxygenated red blood. So this is why it looks sort of burgundy on these diagrams. And then this mixed blood crosses the tricuspid valve into the right ventricle and is pumped out to the pulmonary artery. And so blood then goes to the lungs through the pulmonary artery, and then a percentage of it crosses the patent ductus arteriosus into the aortic arch. And then from there, the blood will go down the aortic arch to the body, but will also fill retrograde the transverse arch to get the head and neck vessels, and then will also fill retrograde this ascending aorta, because down here by this atretic aortic valve you also have the coronary arteries still coming off. And so you actually need this ascending aorta to be patent to feed blood to the coronaries. And as I'm sure you can imagine, if this duct becomes restrictive or goes away, these babies go into cardiogenic shock and will die very quickly. So looking by echocardiogram, here we're looking at a parasternal long axis view, so you can see a large right ventricle, and here you're going to see a small left ventricle. You're going to see a mitral valve that doesn't move very much, and then here is your tiny little aortic valve. And here we see the hypoplastic ascending aorta. And truthfully, I'm going to tell you, this is actually one of the larger ascending aortas that I've seen. Ascending aortas measuring 2 to 3 millimeters in diameter are not uncommon in hypoplastic left heart syndrome. So when this clip plays, it should become immediately obvious that there is something very wrong with this heart. You have this whole right ventricle which comes down and forms the apex of the heart. Here's the ventricular septum. And here's your tiny left ventricle. You do see some movement of the mitral valve, so it's not really atretic. And you see some movement of the aortic valve as well. The other thing that the more astute observers might also notice is that this right ventricle is not functioning very well. So this baby is going to clinically be very sick and is going to need urgent transfer to an appropriate facility that can take care of him or her. So looking from apical, again, you're going to have a big RV, which is cut off a little bit in this image, but the RV is forming the apex of the heart. You have a small left ventricle and a tiny little mitral valve. Here's your tricuspid valve as well. So here you can see that there's some flapping of the mitral valve, but nothing really opens. So this is more of a case of severe mitral stenosis or atresia. And when you look at the aortic arch, you're going to see retrograde filling of the transverse and the ascending aorta. So in this situation, you're going to actually see some red flow in the transverse and ascending aorta, and you're going to actually see a combination of red and blue flow. Anytime you see the aortic arch filling retrograde, that's one of your terrible 10 findings, and you know that there's something seriously going on, because for whatever reason, the left ventricle is not capable of supplying blood to the body. So when you see this filling with color, you see some blue, but you also see a lot of red in here. And if you Doppler, you would actually see bidirectional flow. And that's a very ominous sign. That's a baby that needs further evaluation. So when you're trying to tailor your exam specifically to hypoplastic left heart syndrome, you're going to want to evaluate the aortic arch with color Doppler. And this is a situation, don't be afraid to take a long clip to show the filling pattern. You know, if your echo parameters are set for 2 beats, this is a great time to switch it over to time and give yourself 10 or 20-second loops and just let the aortic arch fill through several cardiac cycles. Don't worry, we won't yell at you for taking a long clip. And you're going to want to use the pulse wave Doppler in the aortic arch to show the blood flow direction, because sometimes just looking at it, it can be hard to tell whether or not you're seeing more red and blue. So using pulse wave to show the directionality is very helpful. If you can, measuring the actual size in millimeters of the ascending aorta can be helpful. Also qualitatively looking at the size of the left atrium and left ventricle. And looking at the movement of the mitral and aortic valves. Those valves by 2D that we were just looking at were moving, but you may be surprised if you actually put color across those valves, there may not be any flow at all across them. And you also want to look at the right ventricle for size and function. The right ventricle is going to be this patient's only ventricle, and if it starts out with poor function, you know, you've got an uphill battle. So a real assessment of right ventricular systolic function is going to be important in these babies. And if you notice this set of findings with poor right ventricular function, that's just even more reason for urgency, and you want to make sure that that finding is communicated to the pediatric cardiologist immediately.